my name is Jennifer and we are false alarms. Today we're going to talk about bioeffects, but in order to talk about bioeffects and understand them, we need to talk about the history of ultrasound. So in 1794, physiologist Lazzaro Spallanzani was the first to study echolocation in bats, which became the basis for ultrasound physics. And then in 1877, Pierre and Jacques Curie discovered piezoelectricity, which is used in transducers. In 1915, Paul Langevin, a physicist, was commissioned to invent a device that detects objects at the bottom of the sea. This was inspired by the sinking of the Titanic and what became known as the hydrophone, which we now know as the first transducer. In the 1920s to 1940s, ultrasound was used as a form of physical therapy. In 1942, neurologist Carl Dosick, first to use sonography for medical diagnosis, used ultrasound through the human skull to attempt to detect brain tumors. And then in 1948, Dr. George Ludwig developed the A-mode ultrasound equipment and used it to detect gallstones in the gallbladder. In 1949 to 1951, Douglas Howry and Joseph Holmes, who were the leading pioneers for B-mode ultrasound equipment, including 2D B-mode linear compound scanner. And John Reed and John Weil invented handheld B-mode devices to detect breast tumors. In 1953, physician Ing Edler and engineer C. Helmuth Hertz performed the first successful echocardiogram. And in 1958, Dr. Ian Donald incorporated ultrasound into the OB/GYN field of medicine. In 1966, Don Baker, Dennis Watkins, and John Reed designed pulse Doppler technology, which led to imaging blood flow in various layers of the heart. And in the 1970s, there were many developments in ultrasound, including CW Doppler, spectral wave Doppler, color Doppler ultrasound instruments. In the 1980s, Kazunori Baba developed 3D ultrasound technology and captured the first 3D image of a fetus in 1986. This led to some ultrasound technology becoming more sophisticated as the improved image quality happened. In the 1990s, adoption of 4D real-time capabilities aided in ultrasound-guided biopsies, including endoscopic ultrasound. And in the 2000s to present, there continues to be technological advancements, which includes compact or portable transducers being able to hook to your phone so you can go to the bedside for the patient if they're too ill.
Hi, my name is Jessica. I'm first going to start off by giving you an intro on bioeffects. First of all, bioeffects are defined as any effect that causes a change to the normal homeostasis. There are two types of bioeffects: thermal bioeffects, which are effects that cause a change in the temperature of tissue, and mechanical bioeffects, which are effects that cause destruction of cells due to intensity threshold. And remember, intensity equals power over beam area. Thermal bioeffects occur when the temperature of a region of tissue rises too high, causing metabolic breakdown leading to cellular damage over time. Temperature rise can be related to duty factor, which is the percentage of time the pulse is on, temporal average intensity. Increased temporal average intensity means higher intensity over entire length of PRP. Scan time. The longer the scan time, the more likely heating will occur. And non-scan modalities, which are more likely to encounter heating as the tissue has no time for cooling between pulses. The higher the duty factor, the greater the time that the pulse is spent on, thus causing a greater risk of heating. A higher temporal average intensity is more likely to cause tissue heating than a lower temporal average intensity, but both will occur over the entire length of the pulse plus listening time. The longer the time exposed to the beam intensity, the greater the buildup of heat can be. Non-scan modalities send the beam over and over along the same line of sight, allowing heat to build up. They have the highest intensity over physical space, therefore they have the highest risk of thermal bioeffects. Scan modalities allow time for the tissue to cool between transmits, so they have a lower risk of thermal bioeffects. It is important that the intensity levels are kept below 720 watts per centimeter squared to minimize the risk of heating. Next, I'll talk about mechanical bioeffects. There is a risk of mechanical damage from interaction between this sound wave and tissue in the body. An example of damage is cavitation. Cavitation is when bubbles are formed in the tissue, they vibrate or oscillate, and in extreme cases, they burst or implode. There are two types of cavitation, first being stable cavitation, which is the vibration or oscillation of the bubbles, and then transient or inertial cavitation, which occurs when the threshold effect is reached or exceeded, causing the bubbles to burst or implode. Unlike thermal bioeffects, the greatest risk for mechanical bioeffects are scan modalities. Examples of scan modalities are 2D and color Doppler. Examples of non-scan modalities are continuous wave Doppler, pulse wave Doppler, M mode, and A mode. Mechanical intensity levels are kept below 190 watts per centimeter squared to minimize risk of cavitation.
Hi, my name is Erica, and we are going to be doing some comparing of mechanical and thermal bioeffects. The greatest risk for mechanical bioeffects are modes of ultrasound with the highest maximum allowable transmit power, and the greatest risk for thermal bioeffects are modes of ultrasound that have the lowest maximum allowable transmit power. As you can see on this chart, in the green we have the highest risk for mechanical, while the lowest risk for thermal, and in the red we have the lowest risk for mechanical and the highest risk for thermal. This is a summary of the comparison of mechanical and thermal bioeffects. Next, we're going to talk about hydrophones. This is a device used to measure intensity. Two of the most common types are membrane hydrophones and needle eye hydrophones. For data to be obtained from the hydrophone, it must be aligned to the beam in each of the transducer planes, which are lateral, elevation, and axial. They are incredibly complicated and time-consuming to set up. The best indication of the risk of mechanical bioeffects is the mechanical index, also known as MI. To calculate the MI, you take the peak rarefactional pressure and divide it by the square root of the operating frequency. As operating frequencies increase, MI decreases. The risk of cavitation increases with lower frequency transducers. Next, we're going to talk about thermal index, also known as TI. TI is an estimation of the maximum temperature rise for the imaging situation. Three types of thermal indexes to best estimate the risks of thermal bioeffects are TIS, which is the thermal index in soft tissue, TIB, which is the thermal index in bone, TIC, which is the thermal index in cranial bone. Absorption in the body increases with collagen content, therefore bone will have a higher risk for thermal bioeffects. So now we'll talk about some advantages and disadvantages of bioeffects. As there really are no advantages to bioeffects per se, there are lots of advantages for ultrasound in general. They're used for a plethora of diagnostic uses. It replaces or is used in unison with other procedures, such as a CT or an MRI. They're more cost effective, which means they're cheaper than the MRI or the CT. And they're also easy on patients, meaning they're non-invasive, such as other invasive procedures that could be used. So bioeffects can also be used for therapeutic and focused ultrasound. They provide ablation of problem tissues and different problem areas. So now we'll talk about some disadvantages for bioeffects. Indices have given us a safety guideline. to use for bioeffects to make sure that we're staying within reason. Tissue heating is the most common concerning thermal bioeffect. Mechanical bioeffects can cause cavitation in the body tissues, and cavitation can result in cell lysis, which is the breaking down of the membrane of the cells. And you always want to use ALARA while practicing ultrasound.
The ALARA principle was introduced in 1990 and is defined as low as a reasonably achievable. Its predecessor, ALAP, which is known as low as practicable, was used until 1990. The principle states only use ultrasound when medically necessary, keep scan times as low as possible, use minimum power settings to produce a diagnostic image, increase transmit power if clinically necessary so you don't miss diagnostic information due to underpenetration. The AIUM, the American Institute of Ultrasound and Medicine, states no recorded bioeffects observed due to temperature rises less than or equal to 2 degrees Celsius above normal for exposure duration up to 50 hours. Pop quiz time! What is the square root of 3,793,588? Now don't forget, you can't use your calculator for the registry. Haha, just kidding, false alarm. Seriously though, what bioeffect does cavitation fall under? That's correct, mechanical bioeffect. What are the 3 different thermal indexes? That's right, thermal index in soft tissue, also known as TIS, thermal index in bone, or TIB, or thermal index in cranial bone, TIC. What does ALARA stand for? Correct again, as low as reasonably achievable.